Good morning. My name is Adrian Rohrbasser and I'm mainly a GP. As you might recognize the differences in the presentation too. I'm a GP and not an infectious specialist. It's my first typo. It's not influenza-like infections, it's influenza-like illness. So whatever has similar symptoms like influenza, we are going to talk about. So it's about guidelines. We try to develop guidelines for primary care physicians, also usable for other specialists. And we're talking about a syndrome, not a disease. Until now, we had a guideline on pneumonia, and that's only a small part of people who are actually coughing all the time during the seasons. So we try to concentrate on the syndrome and not on the disease, the pneumonia. So what we're talking about now is acute respiratory infections, influenza-like illness, and overall we want to avoid too many tests and the overuse of antibiotics. Okay, it was the interdisciplinary process. We were involved as general practitioners and infectious disease specialists, and we used existing guidelines, of course, NICE guidelines, guidelines for lower respiratory tract infections, influenza guidelines from the WHO, etc., etc. We used different kinds of sources, and we used a lot of discussions among experts, and we also involved GPs in the French-speaking and German-speaking part of Switzerland. So I try to guide you through this new syndrome guideline, and we follow the usual pattern. We try to define what it is about. We try to concentrate on red flags to exclude those who should be treated at hospital. We discuss tests and treatments, preventions, a little bit about references as well. The definition is that it's an illness, influenza-like illness lasting less than 3 weeks. And it affects the respiratory tract, so mainly coughing. But as soon as you have a huge overlap, I mean, you have a sore throat, you have a fever, you have sputum, you have all kinds of things at the same time. But you should not have an alternative explanation than an infectious disease for these guidelines. So this is about coughing, cause of infectious diseases. As I said, it's a huge overlap, because as soon as you have someone with a sore throat only or mainly, you may refer to the guidelines on pharyngitis. If you have ear pain, you may refer to the middle ear infection guidelines. If you mainly have a rhinosinusitis problem, it's the guidelines on the rhinosinusitis we should consult, and not influenza-like illness. If we have an influenza, we should keep in mind that depending on the age, we may have other symptoms than in the respiratory tract infection. The red flags, as soon as we do have a red flags, we should send people to hospitals. As soon as you have someone who has a poor overall clinical impression, I can stop at my practice and send them to hospital. If the systolic blood pressure is very low, below 90, this is a red flag. When you have a breathlessness and decreased oxygen saturation, if you have blood in your sputum, if you have stridor, if you have a severe pulmonary disease or a severe immunodeficiency, you should be treated at the hospital level and not at the practice level of a GP. So these guidelines are not about COPD stage 3 or more, or pneumopathies with oxygens or non-invasive ventilation. It's not for people with HIV, it's not for people who have a transplantation of any organ, it's not for people on steroids more than 20 milligrams over a longer period of time. So it's important to keep in mind what these recommendations are about. Then you have two groups of people. One group is doing fine anyway. Whatever we do, they're going to be fine. And it's important to recognize them. So it's cough and very unlikely to benefit from any antibiotics. And that's the case if you have a cough and nasal discharge and or a sore throat or hoarsenesses and a mild fever and absence of any red flag. and then you're safe. You should not test anything. You should recommend symptomatic treatment if they want to have one, but otherwise you should not do anything but inform people that they will get well again. And then you have a group of intermediate to high probability to actually benefit from antibiotics, and then you have a fever exceeding 3 days, you have breathlessness and or tachypnea, you have a focal abnormal auscultation, and you may have tachycardia as well. If you have more than one of these symptoms at the same time as you're coughing, you should start thinking a bit more as a primary care physician. And what you start thinking about is using an inflammatory marker to distinguish whether this is something serious or not. So we keep on saying this, do no test, keep on with symptomatic treatment. If you have a low probability to benefit from any antibiotics, if you do have a slight or intermediate or high risk, chance of benefiting from antibiotics, you should perform a test and you should choose an inflammatory marker. If you end up in between, if you really can't make up your mind where you are at the moment with the patient, you should do a shared decision making with the patient. They usually have an opinion too, and it's good to share them, share the perspectives. About testing, what are the tests you can take? X-rays are not routinely recommended anymore in primary healthcare. They are not good enough. The sensitivity and specificity are too low. You should either use inflammatory marker, or if you are good at it, you can use a long ultrasound, which is quite good as well. But you should be a trained operator, otherwise it doesn't work. I keep saying this, do no tests and only symptomatic treatment if you're in the low risk group. If you're in the intermediate to high probability to benefit from antibiotics, you can do an inflammatory marker. At the moment, it's only CRP that is available. If it exceeds 100, you should really consider antibiotic treatment. If it's below 50, you have all the time you need if the patient is in a good state. And then you can go on with symptomatic treatment. And then very often you will have an intermediate group between 50 and 99. It's not a cutoff. I mean, it's a combination of different things like the state the patient is in, the status I've taken, and then the situation I'm in. And then I can decide on a shared decision-making process with the patient. We developed this kind of helping tool to make it easier for the patient to understand what the chances actually are of any antibiotic helping him or her. And the effect size is quite small and the side effects are quite big. So it's really a trade-off you should discuss with the patients. When it comes to symptomatic treatment, we should be aware of that they last quite a long time. So never ever tell a patient your cough is away after 3 to 5 days. It will not. I've had a cough 4 weeks ago, a cold. I'm still coughing at night. It takes a long time, and never ever tell them you're going to be fine within 10 weeks. They will come on and end up in emergency departments because they're still coughing, etc., etc. So coughing will last quite a long time. Dyspnea will decrease faster, but you will have some kind of sputum quite a long time as well. Does symptomatic treatment really work? And I'd like to tell you that it has a very, very moderate effect. Don't promise too much, otherwise they will end up coming again and again, and they will end up at the ED because you give them dextromethorphan. They think the cough is going to be gone, and it is not. At best, it will decrease a little bit, but not very much. Codeine, in my opinion, does not work at all, and this is in line with the NICE guidelines. Codeine is not recommended anymore. And dextromethorphan has a risk for abuse, especially among younger people. Phytotherapeutics or honey, we've done a thorough scoping search, and we only find some evidence on IV and thyme. That's the only thing that seems to work a little bit. Cough is not going to disappear, but maybe a bit more bearable. The same is for honey, because it may decrease the frequency and severity of cough and improve sleep quality as well. Mucolytic agents like acetylcysteine show only a slow and moderate effect. Slow because it only comes after a week, so it takes a week to improve. And that's why when the cough improves a little bit anyway. All the rest does not work. Bronchodilating agents should only be used in people who have asthma. Steroids should only be used in people who have asthma or similar pulmonary diseases. So the empirical application of antibiotics, if it's indicated at all, we should use amoxicillin first choice. If you have any comorbidities in your respiratory tract infection, you should add clavulanic acid. The left side is for people who have allergies. The duration of the therapy, we should only use antibiotics as long as they are needed. Sometimes, if people improve very fast, you can quit after 3 days. So you don't have to go through the whole cure of a whole package. You can quit earlier. Microbiological testing to decide on antivirals. So if you start thinking about taking tests on any virus, you should ask yourself, will the result change my clinical management? And as a primary care physician, most of the time I say no. Because if I really sick patients, where I really want to know whether this is a influenza or a COVID virus or anything else, I send them to hospital. The turnaround time is quite important too, because if I take a test, I get the result the day after, sometimes 2 days after. And then it's not relevant anymore. So that's especially for influenza, because the rapid tests are not recommended. They do not work for this indication. And the PCR I get too late. I mean, it takes at least 1 day until the patient comes to see me. It takes at least another day for me to get the result. And then it's too late, because I only have a window of 48 hours. Similar, it's for COVID. If I really want to treat someone for COVID, it's usually a serious disease, and I usually send them to hospital for this. And we should refer to the guidelines about COVID in this case. We do have a narrow window. That's really important to know. We should not just test whether it's an influenza or not, because treatment costs are not covered by health insurance companies. And it's quite expensive. It costs 150 francs, and the Tamiflu costs 50 francs, and the effect size is very, very low. Prevention, so the only thing that really works is actual vaccination. We should recommend vaccinating against pertussis, influenza in risk patients, same for COVID, PCV, children and risk patients, and as you heard, RSV as well. Chemoprophylaxis for influenza is not really working very well, and it's not paid either. So it's really only in severe cases and really sick people, and probably they should be sent to hospital anyway. The take-home messages I want to tell you is that you should always take a test before you do anything. If you prescribe antibiotics, you should do a test. If you come into the situation of prescribing antiviral substances, you should also take a test. And CRP works quite well. PCD is not recommended yet because it's not paid at the PCP level, at the primary care physician level. It is paid, as far as I know, in the emergency department, and that's a slightly different population that ends up there. Thank you. That's a team who worked very hard with these guidelines. I hope we could keep them short and simple and understandable.